Okay, I'm glad to have this opportunity to discuss managing dose issues when it comes to neuro CT at least. We'll have about a half an hour to chat, and we'll start with a perspective on the risk of radiation, and I'll share some of the observations of the leaders in our field. We'll then look at opportunities to affect radiation dose by looking at optimizing the techniques that we use. And then I'll finish with a module on some of the novel reconstruction methods that allow us to get gold standard image quality at much lower doses than we ever have in the past. So, what's going on in CT? Well, certainly the volume of CT has risen quite a bit over the years, and while there are some statistical suggestions that this is plateauing, I think that's largely because of billing. The way that billing has changed, I think, with the ubiquitous availability of CT, the great power of this modality, I think we're in no danger of CT fading away in the near future. And this is a concern because of some changes with respect to radiation dose in the population. At one point, radiation dose from diagnostic imaging was a small percentage of the radiation that the population received. Now it's about 50% of what the population receives. And to some folks, that's a grave concern. And the question is, how much of a concern is this? How much fretting should we do over the radiation dose with respect to diagnostic imaging? So, to get some perspective on this, and my observations are not nearly as valid as the ones you'll hear from the experts in the field, I'd like to share some points made by the American Association of Physicists in Medicine in their statement on radiation risk from medical imaging procedures. And they remind us all the things that we hold dear as physicians, that medical imaging procedures should be appropriate and conducted at the lowest radiation dose consistent with the acquisition. What you're actually looking to acquire. If it's a high contrast detectability bone study, it could be a very low dose. If it's a low contrast detectability study looking for subtle metastases, the dose wouldn't necessarily be higher. Any discussion of the risks related to radiation dose should always be balanced by an acknowledgement of the benefits of the procedure. All good, solid tenets. Now, here's where it gets a little more interesting. They state that the risks of medical imaging at effective doses below 50 millisieverts, 50 millisieverts for a single procedure, or 100 millisieverts for multiple procedures over a short time are too low to be detectable and may be non-existent. Now, to put this into perspective, a head CT typically runs about 2 millisieverts. Okay, so we're talking about many factors higher doses still being cited by the AAPM as having virtually no risk. They also state that these predictions of hypothetical cancer incidence and deaths in patient populations exposed to such low doses in the range of diagnostic imaging are highly speculative and should be discouraged, because these discussions, and particularly these sensationalistic articles in the public media, cause patients and parents of patients to refuse medical imaging procedures. And it's really much easier to estimate the risk of avoiding the CT scan and not getting the information than it is to assess the risk associated with the CT. And I think that's really a key point. Now, the physicists in medicine got together. There was a summit back in 2012, and there were experts in the panel, experts in the audience, and they came out with a position statement from their meeting. And they state that the risk of harm from effective doses of less than 100 millisieverts, that's 40 some odd head CTs, a highly controversial topic. And at the effective doses associated with diagnostic CT, and they state that 1 to 12 millisieverts, I don't think we really get up near 12 millisieverts on the Sinai campus, but at that range, between 1 and 12, the risks are extremely small and may in fact be zero. Now, this comes from, their assurance comes from the fact that the background radiation that the population receives varies between 1 and 10 millisieverts. Say you live up in the mountains in Colorado, you might receive 10, and other sites you'll receive 1. And they cite that there's never been any stratification of cancer risk. In other words, the areas of 10 have no higher cancer risk than the areas at 1. And therefore, if you can reduce the radiation you receive from CT to a fraction or no greater than the background levels, you should be able to reach a dose at which the long-term risks are felt to be negligible. All of those statements aside, so again, I think some of the fear associated with diagnostic radiation is not well founded. On the other hand, if we have techniques to reduce the dose and maintain our quality, I think that's really the ultimate goal here. The only reason I put that preamble in is to sort of emphasize that we should never sacrifice quality. or almost never sacrifice quality in the interest of dose reduction. But if we can find a way to maximize quality or maintain our quality and do it at lower doses, I mean, that's where our efforts should be directed. And in that light, we'll talk a little bit about making sure that our techniques are set up to be as low as reasonably achievable. We'll talk about some of the impacts of techniques like dose modulation, and again, we will eventually translate into some of the new reconstruction methods. So what would I recommend for some optimization? Well, one of the first things that comes to mind is just to use less tube current, lower MAS values. And depending on what scanner you're using, you might be setting a higher noise index, and probably more common in the industry is to use a lower reference MAS, essentially telling the machine, look, this is a goal, this is a circumstance where I want you to use less dose. We'll transition in a while talking about low kV, which I frankly think, with respect to contrast agents, is one of the more interesting principles in this particular presentation. But just to, as an overview, lower MAS is an opportunity anytime we're looking at a high contrast detectability exam, whether it's a temporal bone or a sinus exam, or even a neck study tends to be very low. In other fields, it might be a chest CT that can be done with virtually no radiation. You'll hear from other folks talking about that. But this is actually a typical CT of the sinuses, which many of the folks in neuroradiology understand can be done with virtually no radiation. I mean, this is a 16 MAS exam. It's almost the way someone might put perfume on. You turn the dose on, 10 minutes later, walk through the room and get your exam. I mean, it's really a very small amount of radiation. So what happens in neuroradiology is you get a little bit of pushback. I remember the case where I read a sinus CT and I found a brain tumor, and with these ultra low doses, I can't see the brain parenchyma anymore. So, what's the solution for that particular dilemma? Do you then go ahead and do a high dose exam on all of your patients so that you get that small incidence of incidental findings that you might be able to pick up, or is there some other secret? And I think the good news is there are some techniques that you can do to take an exam that's ultra low dose and still get a good low contrast detectability study, and I'd like to talk about that. So here you see a typical axial image done at ultra low dose, and this is a typical sinus study, so it's a high resolution algorithm and a very thin slice, and it makes for a perfectly acceptable bone window. I don't know if you can see my pointer. Is my pointer on the screen? Okay, you can see the patient's got some ethmoid sinus disease, some neural sclerosis, a typical chronic sinus disease study. If we try to take that same image and project it at a window that we would be able to see the brain parenchyma, you can see a number of problems. There's virtually nothing diagnostic in that image. Now, so what do you do? I mean, what's the solution? Well, fortunately, there is a solution. You can do things like changing the amount of iterative reconstruction, often to take a high-res image and make it acceptable. You can go up to the highest levels of iterative reconstruction. That might be a level of 100 if you're using a blended technique, or a level of 5 if you're using one of those step techniques. You can change the kernel, even though you may want to use a diagnostic image at a high-resolution recon. You might decide to look at the brain images or the neck images, soft tissue images, at a very soft recon. There's no need to get that kind of spatial resolution. You can also alter the slice thickness. We might want isotropic data for multiplanar reformatting, but if all I want to do is check the orbits or check the brain, I might be able to be satisfied with a 5 millimeter cut. And the summation of all of that gives you much higher signal to noise. And again, you also can manipulate field of view to get the voxel size to be larger, and again, add more signal to noise. So let's walk through those steps. So here you see the routine image I showed you earlier on the left-hand side of the screen. It's a 0.625 millimeter cut, typical high-res algorithm, and it looks like garbage at a soft tissue window. If I simply just double the slice thickness, is what you see on the right-hand side, things improve a bit, but I doubt you'd see much subtle in the brain parenchyma. Now, if we simply take that same slice thickness and soften the algorithm, go for a normal soft tissue algorithm, you're starting to see the brain appear in there. Now, mind you, same low-dose study. We make the slice a little bit thicker, and you're starting to approach something that you might find acceptable. And again, going to a 3.75, looks like a routine brain image, and at 5. So this is a way to get an absolutely acceptable ability to look at the brain, look at the neck, look at the orbits on a sinus study, yet keep your dose at vanishingly low levels. And these are techniques that are common to any manufacturer. It's done in slightly different ways, but it's a wonderful technique to get the best of both worlds without increasing the radiation just for the point of picking up incidental findings. So you can actually take that image and turn it into that image and do this routinely. And with a modern scanner, there isn't even any workflow impact. You just program it all in, and it just runs out that way, which is really quite nice. So you can start to do these exams at very, very low dose and get the best of all worlds. This is a sinus CT, excellent high contrast detectability, nice spatial resolution, yet I can make these perfectly acceptable orbital images of the axial and coronal plane, again, without increasing the dose. And I think that's a very important principle. You can see from this particular exam, it gives a wonderful orbit image, has a CTDI of 8. And to me, I think of the dose per slice, or the dose style of the exam is always measured in the CTDI. How much effort am I putting in? How much radiation am I putting in? And the DLP is sort of it's a factor of how much I'm actually scanning. So in this case, a CTDI of about 8 is really quite nice. You saw respectable brain images. The ACR guideline for CTDI for a brain image is up to 80. Okay, this is 10% of that, and it gives you a respectable exam. Now, we're here to talk about contrast agents and the impact that CT, the changes you might use for your CT imaging, factoring in the impact with contrast agents. And that area, with respect to that topic, it really is all about the KVP, how we change the flavor of the beam, the nature of the beam, rather than the power of the beam to best leverage the use of contrast. That is about in terms of CT imaging, and that's using lower values of the peak energy, the KVP. The impact of changing the KVP is enormous. If you drop the KVP from 120 to 100, that's 17% drop in technique, results in a 40% reduction in dose. And assuming that you don't compensate for that reduction in dose in some way, that's an enormous dose reduction. Now, one of the few things that I remember from physics as a resident is that as the KVP goes down, the contrast resolution goes up. And we can leverage this in neuroimaging to get better gray-white differentiation, more subtle details available. And you can see in the lower right-hand side of the screen, this patient with a subdural, you've got fairly impressive gray-white differentiation. And this is in part supported by the lower KV. I don't know if you can see the dose length product in this particular case, where the CTDI for this exam is under 30. So, something like 40% of the ACR guidelines. So here's the same patient, different scanners to be fair, but different days, different scanners, pre-op and post-op. This patient has a colloid cyst in the anterior third ventricle. This exam, where you can actually define the posterior limb of the internal capsules, is done at 100 kV, the lower level, lower dose, in theory, unless I compensate. Here's the one done at 120 kVp. Now in this case, the dose is about the same. Same patient, dose about the same. On the left-hand side, you see 100 kVp, better contrast detectability, okay, low contrast detectability. On the right-hand side, you can't even see an internal capsule. So dropping that KVP has an impact on routine day-to-day imaging. Here you see the same patient, in this particular case, a lower dose on the right, 100 kVp on the right, 120 on the left. At the very least, it's not worse, even though the dose is lower, but I think the gray-white differentiation is a little greater on the right. And again, just leveraging the lower KVP to slightly improve my images, at the same time getting a lower dose. 30 on the right, 40 on the left, a DLP of 518 on the right, 713 on the left. Just a nice way to accomplish all of our goals at the same time. Now, some of the more modern machines have multiple steps along the way. It used to be 80, 100, 120, 140, and we commonly used 140. You won't find 140 used on any of our CT scanners at our institution because we just don't think it's the best approach in this low-dose era. And some of them have actually more incremental steps. You can do a 90, you can do 110, 130, even 150 if you felt the need. And here you see a typical exam of the head done at 110 kVp, again with very respectable low contrast detectability or gray-white differentiation. Here you see 100 kV, which is really probably our most common technique for head imaging on our campus. And you can see here both really excellent low contrast detectability on the non-contrast exam. And once the iodine comes in play, it really does pop at the lower kV levels. So I mentioned you drop the KVP, you get a huge drop in dose. And the secret to that, I mean, the dirty secret to that is if, in most circumstances, if you drop the dose with KVP, you've got to raise it back up with your MAS to keep your images as good at the same level of quality. So it's not a free lunch circumstance. You really don't win if you raise the MAS up to keep the noise index the same. So what's the fuss? Well, it turns out that if you're doing contrast-enhanced imaging, particularly CT angiography, you don't have to bring the dose back up with MAS. You can actually stay at a much lower dose level. And that's fundamentally the principle we're talking about here, is that iodine visualization, particularly for angiography, may not require the usual low noise levels that we use for diagnostic imaging. It's well known that there's a greater attenuation of the X-ray beam as the X-ray beam flavor gets closer to the K-edge of iodine. And it's been shown that the attenuation values of iodine-enhanced vessels at 80 kV are almost double that of 140 kV. It wasn't too long ago that we might do a CT angiogram at 140 thinking we needed that power. Now we know the best approach is actually to be on the lower side to make the iodine work for us. And it's been years since we used anything above 100 kV for our angiography. And as the tubes mature, as the scanners get better, we can start to use lower and lower levels. Here you see a routine CTA of the head at 100 kVp. I don't think it's widely known that CT angiography, particularly neuro CT angiography, is a very low dose procedure as things go, a fraction of what a head CT would be, because again, we have a different goal. We're imaging iodine as opposed to imaging brain parenchyma. On our campus, all the head CTs now are done at 80 kVp or less. Here you see a patient with a middle cerebral artery stenosis, nicely done at 80 kVp. Here you see the same patient seen at two different visits on two different scanners. At the time, on the right-hand side, you saw our standard protocol, which might have been 100 kVp. The dose here is a CTDI of 26, and the DLP is probably not worth commenting on because there could be a variability in the length, but a CTDI of 26. Same patient on a recent follow-up at 80 kVp, the CTDI is 9. Okay, the image quality looks the same. So again, imaging iodine, lower kVp, lower net doses without a sacrifice in quality, which I think is really a really nice and elegant way to use the technology. Here's a patient with a left carotid occlusion. You can see on the, it's a left carotid occlusion, I'm sorry. You can see the carotid here is occluded. The opposite side looks normal. Typical neurovascular study at 80 kVp, much, much lower doses than we're accustomed to. Now, modern scanners can do 70 kVp, and this is actually a technique that works very well in the brain, strangely enough. You would think it wouldn't with all of that bone, but it turns out it works very, very well. This is a patient, actually this is a CT angiogram that was actually extracted from a perfusion study, but it's a 70 kVp, 150 MAS, 40 cc's of a high concentration contrast agent, and frankly, all the contrast enhanced images I'm showing you here are all done with a 370 contrast agent to maximize iodine flux, but again, very, very low dose exam. Now, just because I have some friends that work in body imaging and I have responsibilities for this area, I'm just going to show you one example of what we do for our abdominal imaging on our more modern machines. And we actually shoot an arterial phase, a true arterial phase, on all of our multi-phase abdomen exams. We get a single spin with a larger area detector done at 70 kVp. The dose of this exam runs usually less than a CTDI of 2. This is a 1.9 CTDI and a 26 DLP for the single spin exam. And you can see the images, just what you'd expect. There's no drop in spatial resolution. The noise levels seem appropriate, and this is working out very well. And you can see this might be part of an oncology assessment where you're used to getting a late arterial phase, but a single spin, half second, CTDI of, what do they say, 2, we can go ahead and get a true arterial phase, which might have some impact in routine clinical circumstances. Now, as a neuroimager, the area we've had the greatest concern over the recent years is in CT perfusion, because this can be a relatively high-dose exam, and there are some radiation-sensitive organs in the area, like the lens. And the efforts that people have used to reduce dose with perfusion include using lower tube current values, okay? But you can only go so far before your quality tends to suffer. You can use a shorter scanning window, essentially scan less long, and that does make you more susceptible to physiologic variations. We try to get all the way through the cycle, from the pre-contrast imaging, through the arrival, through the washout, back to baseline. That's the ideal circumstance. But when you keep the scanning window a little bit more narrow, you sometimes run into these type circumstances where you didn't finish the exam, you didn't get your venous return. So there are limits to how short you can actually make these exams. You can also say, instead of sampling so often, you can sort of widen out that interval so you don't sample so often. You can go as long as you like, but not as often. But the appropriate sampling interval is controversial, and I think it's fair to say that there are limits to how wide you can go. Particularly when you're sampling with regular intervals, how wide you can actually go out there. So what else can you do to reduce your dose? Well, one of the best ways to reduce your dose, since this exam is really all about imaging iodine, is to use the lower KVP values. Our perfusion imaging on our campus now with 2 different vendors is all done at 70 KVP. The same principle we talked about beforehand, better matching to the iodine K-edge. This was actually proven out in a paper early, I can't see when this was, early 2014. They showed that this was a viable approach for 70 KVP. We took that same approach for our work, but we also added a couple of things. We took that sampling interval we talked about earlier, and you did a bit of variability. Sometimes we scan slowly, sometimes we scan quickly. And that allows us to break that relationship between dose and scan length. And I'll show you some examples of that. This allowed us to go to an extended scanning period, so we never missed the venous return. And the best dose reduction technique is pulling the CT angiogram out of the perfusion study, so we don't actually have to do the dose of a CT angiogram as small as it actually is. So this is the way we sample at our institution. The top row would be a standard approach every, say, 1.7 seconds. The bottom is what we actually do. We go through every 3 seconds before the contrast gets there, every 1.5 seconds during the key periods of contrast passage, and then out as much as 7.5 seconds just to make sure that we get the full venous return. Much wider scanning window and accomplished at reasonable doses. And here is an example of both a time-resolved CTA and a perfusion study done at 70 KVP at our institution. Now, we published this last year, this combined approach with all of these innovations, and we showed that we were able to get better quality, qualitatively and quantitatively better quality at substantially lower doses. And here you see examples of 2 different patients with roughly the same disease done at 2 different KVPs, at least qualitatively on the screen. They look about the same. Both look very good. If you actually look at the quantitative numbers, the CTDI dose reduction at 70 KVP was 45% less per pass. So equivalent or slightly better quality, but 45% less per pass, and actually, because of the variations in what we did, 13% less per exam, and I think that's a big difference. I won't actually go through the quantitative numbers here except to say that in many ways there was a statistically significant benefit at 70 KVP. And here you see another examination patient with an infarction in the left middle cerebral artery territory. The time-resolved CTAs at the bottom, extracted from the perfusion exam done at 70 KVP, and the very respectable quality of perfusion exam done again in the bottom row is 70 KVP. So once we've established that KVP manipulation is a good idea, the question is, how do you do it? Do you set up your protocols to just do 70 or 100 or 80 when you think it's indicated? Or do you kind of give the machine a guide and say, you know what, this is what I'm looking for. It's a contrast exam or it's a non-contrast exam. Go ahead and look at the scout, make the adjustments, and do it when you think it's best. It has, and this is all based on the scout. And again, what you're trying to do, is it non-contrast, is it contrast, as I said. And it turns out that if you let the machine do it, and these techniques are now almost ubiquitously available, every major vendor has some form of automated KV selection. Could be Care KV, it could be KV Assist. It turns out if you let the machine do it, as opposed to the protocol-driven approach, you end up with a higher number of cases where you use lower KV, and that has to be in the interest of patients because of the principles we talked about earlier. Now, dose modulation is another important technique, and again, this is not ubiquitously used, so it's worthwhile talking about it. This can be done in 2 different fundamental ways. One is in and through plane, so that as you roll around the body, when there's more to penetrate, the dose goes up, and when there's less to penetrate, the dose goes down. And then as we go along the z-axis, you end up using higher doses, say at the lung base, lower doses when there's less solid material in the way, and higher doses up at the shoulders. And here you can actually see the dose profile on this particular examination. This is commonly applied in neuroradiology because when we do a neurovascular CTA, we've got to start from the shoulders. And there was a time where we would do the entire exam at the dose that was necessary to penetrate the shoulders. much higher dose than you would be if you only had to use that dose where you were through the shoulders, and then could drop precipitously as we go through the center of the neck. And you can see in this particular example, this is an older example, but we were using 230 MAS through the shoulders, but when we got to the level of the common carotid artery, we're down to 55 MAS, and only rose as high as 91 MAS when we got to the skull base. And by the way, the key principle here is to keep your image quality the same throughout, but can do this at vastly different doses based on this particular technique. Now, probably, for those concerned about a radiation dose, is the piece that's even more important is the organ protective dose modulation, which again is becoming a ubiquitous technique in the industry. There are organs in neuroradiology that are in the way of our neuroradiology scans that we care about, like the eye. The lens is radiation sensitive, the thyroid gland is radiation sensitive, and what happens in these cases is when the tube is closest to those organs, the counts are reduced remarkably, and they're made up from the other views. So it actually modulates the dose down through the views that cover those organs, and we use this 100% of the time in neuroradiology, and this is also commonly used in body imaging to avoid radiation to organs like the breast. Now, the last piece I'm going to talk about for the last 7 or 8 minutes is the evils in our routine imaging and how this has led to higher dose exams that were necessary. And the images we used for years in CT were based on a very quick and dirty reconstruction method called filtered back projection. These were designed to be reconstructed on a Commodore 64. Our iPhone today is much more powerful than the CT reconstruction engines that were made in the early 70s when CT began. So this was a quick and dirty reconstruction method that allowed you to go fast even with miserable computers, but a lot of assumptions were made, and these assumptions led to significant amounts of noise in the image, okay? And you can see at the doses we use today, you would get an image that looks like that really fairly horrendous image in the lower right-hand corner of my screen where you wouldn't be able to make a diagnosis. So fundamentally, these reconstruction methods left so much noise in the image. Our only strategy was to essentially shout above the noise. We had to use a lot of radiation to get the signal through because there was such a high noise level. And you can see again from these particular examples, today's doses don't give you ideal image quality with those filtered back projections. Essentially, what iterative reconstruction techniques do, novel reconstruction methods we have today, is it reduces the noise floor in the image. It takes the noise out. And once the noise is out, you don't need to shout to be heard. You don't need to use high radiation doses to get the diagnostic information you have in mind. So how does this work? Well, it's a fairly simple process. You still do that projection, but after that projection is done, you go back and compare against reality. And you cycle through in a bit of a Bayesian experiment, constantly comparing and refining over and over again in an iterative, improving fashion until you get a final image that has significantly lower noise levels in it. You can see from this particular phantom, when we look at the noise levels, measured here as standard deviation, at the filtered back projection, they're almost 10 times higher in some circumstances than they are with iterative reconstruction. Everybody's got a method, no matter who your vendor is. The most modern methods generally work better than the earlier methods, but everyone's got a method of iterative reconstruction. You can see the same patient done different ways at similar doses. Again, very respectable quality, frankly, better quality than we're used to seeing in many circumstances. So you can see here at roughly a third of the ACR guidelines, we can actually get a respectable image. Look at the left-hand side. That's what this would look like with yesterday's reconstruction. You can barely tell there's a stroke there. When you look at the right-hand side with iterative reconstruction, is a well-defined acute right middle cerebral artery territory infarction. Again, overall, this has allowed us to reduce our doses for neuroimaging. I would say a very conservative estimate would be 60% compared to what we used to use in the past. Again, we feel that we're not giving up any quality at these dose reductions. Now, there is some concern in some folks that this might be a filter. It might be softening my image. I might lose something. Well, I call your attention to two particular things. One is a filtered back projection. It's full of filtration, okay? That's why they call it that. They did all kinds of things to make the image look reasonable. The second piece is, if you look at this phantom, there's no inherent reason why a iterative reconstruction should be a lower resolution algorithm than what we're used to. In this case, you can actually see an improvement to the spatial resolution. One of the tactics that some folks take with iterative reconstruction is actually using a higher resolution kernel than they could have used in the past because of the ability to do dose reduction. And in that case, you're actually getting better images than you're accustomed to. But I can tell you that in clinical practice, we've had great success with low contrast detectability, with high contrast detectability. We're getting the images that we need, and we use this ubiquitously in our institution. It's one of the reasons that we can do this bone work at very, very low doses. We've used this successfully in looking at the soft tissue neck. We've used this successfully in looking at the head. And frankly, the area where we're really most passionate about this is the patients who go through the neurosurgical ICU. Okay, these people get scans every day, sometimes 2 a day. And if they're in there for 2 weeks, they're going to get 20 or 30 CT scans. Now, while I'm not extraordinarily concerned with the radiation dose from diagnostic imaging, even though it isn't necessarily sound physics-wise, I am concerned when somebody's getting 21 CT scans in a week or two, and particularly when they're a younger patient with perhaps a subarachnoid hemorrhage going through a bit of a crisis. This is a patient with a colloid cyst. This is a small sample of this patient's exams. So we actually designed a ultra-low dose protocol simply for follow-up. The principle here is we're designing an ultra-low dose compromised protocol used just in the follow-up of these patients. And you can see the kind of doses that we're getting for our head CTs in these patients of 0.5 millisieverts. Very, very, very low. So again, what's the principle here? A compromised exam at lower doses that still gives me my information. Is the catheter in position? Are the ventricles the same size? Is the hemorrhage increased? And the like. So I think this is really a wonderful technique for routine day-to-day work. So I think I'll stop there and say that I hope these principles are useful in terms of modifying your practices at the CT scanner. And if you have a relatively new machine, opportunities like ultra-low kV are there. Sometimes it's an educational effort that things like CT angiography can be done at ultra-low dose. I hope that was useful. Thank you very much for your attention.